Good afternoon, ladies and gentlemen. Welcome to the webinar organized by the European Reference Kidney Network in conjunction with European Society of Pediatric Nephrologists. So the topic of today is genetic causes of nephrolithiasis and nephrocalcinosis, and it will be presented by Karl P. Schlingmann from Münster, Germany. My name is Elena Levchenko. I am pediatric nephrologist from Leuven, Belgium, and I will moderate the webinar for you today. So let me introduce our speaker, Karl Peter Schlingmann. He is an attending associated professor in the Department of General Pediatrics at the University Hospital Münster. Karl Peter is really famous for his studies in the hereditary disorders of renal electrolyte handling and iron homeostasis. He has identified several genetic defects, new genetic defects, and he really published very important papers in the high-impact journals such as New England Journal of Medicine. Karl, the real expert in the topic, he is going to present to us today. So please don't be shy and prepare your questions because he will be able to answer them all. You can always ask your questions during the presentation in the question bar in your attendee panel, and we will answer your questions at the end of the webinar. So the webinar will be recorded, so you can see the recording later on the website of ERKNet. And yeah, I think Karl Peter, the floor is yours, and we are really very much interested to listen to your webinar. Please start.
Yes, thank you very much, Elena, for the kind introduction, and ERKNet for the opportunity to present these data. Here I will start with some general information about kidney stones and kidney stones in children. This will be followed by a more detailed overview on the different entities involved in pediatric nephrolithiasis. And at the end of the talk, I will try to provide an overview on studies that have in detail looked at larger cohorts of children with kidney stones and nephrocalcinosis. But before starting, I would like to refer to previous webinars that had similar topics, or let's say that introduced you to some of the entities in much more detail than I can today, because I will try to give you an overview on the different entities involved in kidney stone disease in children, rather than to go too much into detail into a single entity. So especially Shabir Moshala in March of this year already talked on. Yes?
Sorry to interrupt you, but we cannot see your slides moving, or at least I can't see it.
I'm on the second slide, past webinars to mention.
No, for me it's still the first slide. I don't know. Elena?
I'm sorry.
Yeah, for me it's also still the first slide, so I thought you were just talking.
Oh, I'm very sorry. I'm on. Is it possible now? Can you see the second slide now?
No, maybe you have to click on the desktop again to.
I will try to stop now the presentation again and then restart it. Do you see the second slide now?
No, it's still the first one.
I don't know what the problem is, to be honest.
Maybe you have to share your screen. And yeah, now we're on the second slide. Perfect. It's perfect.
Okay, perfect. So I'm very sorry. So basically, I previously referred to all these previous talks on some of the topics involved in pediatric kidney stone disease, like primary Hyperoxyloria, for example, Santinuria, or renal tubular acidosis. Specifically, I would like to refer to Shabir Moshala's talk on the genetics of kidney stone disease. But before starting now with a general overview on pediatric kidney stone disease, I would like to introduce you to the topic with poll question 1.
Okay, so everybody can see the question, I guess, and the question is, have you performed genetic analysis in patients with nephrocalcinosis and kidney stones? So please select your answer. Okay, can you see the answers, Karl Peter?
No.
Okay, then I will read them for you. So 16% of the audience never performed the genetic test, 50% in single cases only, and 33% regularly.
Okay. So basically, the majority of the audience have performed genetics already in single patients, but they do not perform it on a regular basis in many patients. So I will maybe try to highlight the importance of the testing, at least for a subcohort of these patients, or for patients with recurrent disease, or even more important, with a deterioration of renal function, for example. I hope you can see now the following slide. So if we talk about kidney stone disease in children or in humans in general, you see that there's a lifetime risk of about 10%, depending on.
I'm sorry, we still see the poll slide.
Yes, I already switched back, but I don't know why it's not working now. I'm sorry. The taser.
So we'll skip poll 2 in this case. I have no idea. I have to. Do you see now the next slide?
No, not yet. It's still the poll.
I'm sorry. I don't think I can change that.
Yeah, I tried.
So.
Wait a second.
Just please be patient here. We can see you now, Karl Peter.
You can see me?
So I will assign you again as a moderator, and then you should be able to share your screen again. I'm sorry for the inconvenience. Yes, yes. Now it's working.
Okay. So if we talk, should I repeat it now? You can see now the slide with a nephrolithiasis overview.
Yes, we do.
Exactly. Yes.
So there's a lifetime risk of about 10% in men, 4% in women, and there are no really good numbers for children, but it's considered 10% of the incidence in adults, and that equals up to 8 to 20 per 100,000. Generally, children of all ages are affected, but the median age that you can see here appears pretty young, so even preschool age for boys or primary school age for girls, for example. And there's a special entity that we specifically observe in children, and this is, or early in life, this is nephrocalcinosis, and I will come back to that a little later. Generally, if we look at kidney stone disease in children and compare this to adults, there's a higher incidence of identifying an underlying metabolic abnormality, especially in the ones that show recurrent disease or progressive kidney stone disease. I hope you can see now the next slide. This is quite general on the clinical features of kidney stone disease, and I only would like to point out that the younger the child, the more unspecific the symptoms are, like failure to thrive, malaise, or micro or macrohematuria. And then later on, the typical symptoms like dysuria, urinary tract infections, or the typical renal colic might occur more frequently. And there's still a significant number of children identified where the kidney stone is an incidental finding. This is also just a short overview on conservative or pharmacological treatment. Some of these aspects have been transferred from adulthood to children, but most importantly, we have to try to increase the fluid intake. This is specifically important in Santinuria, where we'll come back to that. There's, in general, the advice to restrict dietary salt, but on the other hand, not to restrict dietary calcium, because this bears the danger to increase oxalate absorption from the intestine. And there's also not the advice to reduce protein intake below normal values because of the growing organism that needs the protein. And there are some types of specific, let's say, pharmacological treatments like giving alkaline citrates, magnesium or phosphate. And I put some question marks behind citrates and phosphate because this might only apply to certain subsets of stones that we will see a little later. And of course, there's surgical treatment like in the adult, maybe even more on the with the weight on extracorporeal lithotripsy than operative measures, but I will not go into detail with that in this talk. If we go now to diagnostics of kidney stone disease, we usually start with urine analyses and follow this by serum chemistry or by blood gas analyses, but this is in our hands usually reserved to the follow-up visit maybe, or to severe cases presenting the first time. If we look at urine analyses, you can see here that we measure usually the creatinine and several electrolytes, plus oxalate. Uric acid is mentioned here, as well as cysteine. And before going into too much more detail, I would like to follow this by poll question 3, maybe to get an idea what you usually measure in urine. Stephanie, could you provide it?
Yes.
Okay, the poll is open now, and the question is, which analyses are included in the urine analysis you perform in patients with nephrocalcinosis and kidney stones? And then you have 5 options to answer. So please vote. Okay, so I will read it for you, Karl Peter.
Yes.
So 20% have chosen for option A, 34% for option B, 9% for option C, 29% for option D, and 8% for option E.
Okay. So there's. Can you now see my screen again this time?
Yes.
Yes,
Now it's
great.
going well.
So it appears to be quite an equal distribution around all these possibilities. The different options included the more specialized parameters like oxalate, uric acid, cysteine, but also xanthine as a last possibility. So basically these are especially included in the first analysis, usually in our hands, because we don't want to miss these more rare causes of kidney stone disease, and we try to measure these metabolites at least once and usually in a first setting. The blood gas analysis is especially important because it provides the pH and for the detection of metabolic acidosis, as well as the other parameters. In some cases, we have the opportunity to analyze the stone directly because these cases are referred from the urologists, for example, and we do not see the child, or we do see the child the first time after the surgery has been performed or the stone has passed the urinary system spontaneously. These analyses are basically complemented by serum chemistry, and you can see similar parameters like creatinine and electrolytes. Uric acid, again, oxalate is given in brackets because it's reserved for rare cases where we suspect primary hyperoxyluria. And I would like to mention here already the parameters for bone metabolism, as well as vitamin D metabolism, parathyroid hormone, and the vitamin D metabolites. And I will come back to those later on. Okay. I already mentioned nephrocalcinosis, and I would like to show you here the different degrees according to Hoyer and colleagues. You can see grade A here with a calcification only of the tip of the medulla, grade 2A where you have like a window frame around the pyramids or the renal medulla, grade 2B where you have a calcification of the entire medulla, and grade 3 where you have basically the loss of ultrasound after the calcifications are present as the most severe degree of nephrocalcinosis. If we look at the etiology of kidney stone disease, like I said, we have an increased opportunity to identify a metabolic abnormality, and that's indeed the case in 20 to 48% of children, according to different studies. We have a urinary risk profile, and that's mostly hypercalciuria, as given here below, in up to 3/4 of patients. And we have a positive family history, most importantly, in about every second child. If we look now at the stone composition in these children, you can see that the stones composed of calcium oxalate as well as calcium phosphate predominate by far. Metabolic stones composed of uric acid, for example, cysteine, compose about 5% of stones in children each. We have struvite as the typical stone associated with urinary tract infections, and we have the very rare entity of xanthine stones in less than 1% of children. If we talk about calcium-containing stones, we have hypercalciuria as the major risk factor in children and as the most common metabolic abnormality present in about 2/3 of patients. If we talk about hypocalciuria, it's very important to have in mind that there are age-dependent reference ranges, especially important that the calcium excretion is normally much higher in infancy and shortly thereafter, and it goes down to the values observed in adults only about the beginning of school age or a little earlier. This is from Matos and colleagues, and we usually use these cutoff values if we look at, especially at young children. And these are provided in mole per mole as well as in milligram per milligram. Classically, hypercalciuria had been divided in absorptive versus reabsorptive. And I still think this is quite an interesting look at things. Because if we talk about absorptive hypercalciuria, we talk about primary hyperparathyroidism or disorders of vitamin D metabolism, as you will see later on. But we have a number of additional entities that lead to an increased absorption of calcium in the intestine. That this is not a real division into two different or opposite parts will be shown later on. But on the other hand, as reabsorptive hypercalciuria, we have a set of hereditary tubulopathies, and these can be disorders of the proximal tubule, and I will show these a little later on, like Franconi syndrome or Dent and Lowe syndrome, or of the distal tubule, like salt wasting disorders like Barter syndrome, FHH and C, so a disorder of the tight junction, and renal tubular acidosis, for example. It's not that easy to divide these entities or to divide hypercalciuria in these two entities only. Historically, the calcium loading test has been used to differentiate between these two entities, but later on it became evident that a number of patients switched from one side to another, precluding this easy scheme to differentiate between metabolic and disorders and tubulopathies, for example. This slide now provides an overview of the different entities mainly involved if we talk about monogenic stone disease, and I would like to focus indeed on monogenic disorders involved in kidney stone disease in children, because if we talk about gene testing or gene panel testing, this usually refers to coding variants in genes involved in these different types of disorders. And I won't talk or go into detail for polymorphisms or risk factors or risk alleles associated with kidney stone disease in children. I will only provide one example that's mentioned later on, that's Claudine 14. But as you can see also here, we have different types of tubulopathies, so disorders of the proximal and distal tubule, and we have a set of metabolic disorders that also lead to increased excretion of calcium salts or specific metabolites that are excreted in the urine, leading to kidney stone disease. And I would like to start with the first entity now, that's Cystinuria. Cystinuria has been also presented in another webinar already, so I won't go into too much detail, just mention some clinical aspects as well as biochemical findings associated with this monogenic disorder. As you can see, there are two main genes involved in the disorders, SLC3A1 and 7A9, both coding for subunits of the apical amino acid co-transporter in the proximal tubule, and I will provide you a scheme on the next slide. So this is really a proximal tubulopathy, not only for cysteine, but also for D-basic amino acids like ornithine or arginine and lysine. The clinic is usually kidney stone disease. The mean age at presentation is provided here with 22 years, but usually the disease can manifest early during childhood. There is a high risk of recurrence, like provided here, with a 5-year recurrence of more than 80%. And this highlights the importance of a structured therapeutic intervention to prevent further kidney stone episodes and renal damage. Chronic renal failure develops in about 70% of patients, but fortunately only 5% statistically reach end-stage renal disease in our days. It's easily to detect cysteine or very high cysteine levels in initial urine analysis, so the diagnosis should normally be pretty easy. And there's an upper limit of solubility of cysteine in the urine that's provided here with around 250 milligrams per liter. And this threshold indeed is pH dependent, but if we reach pH levels above 7, which is the therapeutic goal, then usually the level of 250 should not be exceeded. This is done by forced increase in fluid intake, alkali citrates, and sometimes added thiol-based drugs like thiopronine, for example. But like I said, the details have been provided earlier, so I won't go into detail with this. The genetic story involves these two genes I mentioned. And interestingly, the first gene, SLC3A1, is indeed purely recessively inherited with no significant affection of the parents. But for the other gene, 7A9, there's a significant heterozygote effect, meaning that also the heterozygotes show a milder but detectable biochemical phenotype and can also rarely develop a kidney stone disease, maybe if there are additional risk factors. Here it's shown again that these two different genes code for proteins involved in the apical uptake of basic amino acids in the proximal tubular cell. So I would like to follow this by disorders of uric acid metabolism. And as you can see here, it's like in many other diseases, we have the most severe variant that is caused by recessive or mutations in this X-linked gene HPRT1. And I will also provide a short overview on the metabolic disturbances observed here. And if we have mutations in this gene that impair the enzyme function basically, or leave no residual function of the gene, we get this severe type of disease with mental retardation and additional neurologic disturbances, especially these mutilating behavior in patients. And besides, we have an increased risk of the development of uric acid stones. The serum finding in this disorder is hyperuricemia, and the kidney basically does what it's supposed to do. It excretes the uric acid, and then this is followed by the development of stones. And here next to this, we have a milder variant of the same disease. So this disorder is basically allelic to the other one, but leaves a certain amount of enzyme function intact. So there is basically, in this disorder, there's no neurological phenotype. There's an increased risk of gout in later life because of the hyperuricemia, but the patients usually present with isolated kidney stone disease. Another disorder of uric acid metabolism or purine metabolism is Santinuria, and I won't go into too much detail because these disorders are extremely rare as well, but should be detected. Basically, also these stones have the interesting feature to be radiolucent, so they are usually not detectable on X-ray, which makes the diagnosis sometimes more difficult. Patients have a risk of developing renal failure as well as myositis. If you have this in between, you might be able to detect xanthine or hypoxanthine in the urine. And if we had the poll question before, basically, we are usually not performing these xanthine measurements or hypoxanthine measurements in urine and reserve this to specialized cases. So this indeed might be overlooked on first view and then has to be done after maybe the stone analysis is back, or if we are not able to detect any pathology in urine in a child with recurrent disease. Specifically in serum, there's decreased uric acid, and that's true basically for both genes involved here. And the last disorder I would like to mention for purine metabolism is Dhl Eurolithiasis, also a defect of purine metabolism, with a special appearance of this insoluble metabolite in urine. And especially this metabolite is usually not measured. There's a specific appearance of the kidney stones that are detected in these children with some reddish color. And also these stones are radiolucent. So maybe this might help in the diagnosis of this disease. Otherwise, these cases might indeed be discovered by genetics or by stone analyses, which are able to detect the metabolite. As a last parameter, the enzyme function might be measured in erythrocytes, but this also has to be done only in children where you suspect the disease. So the diagnosis of this entity is really not easy, but it's supposed to be very rare. You can see here the different defects in this complex metabolism of purines, but I won't go into detail with this one. Next to these metabolic disorders leading to Hyperuricosauria, we have two entities or two transporters that lead to increased urate levels in the urine by a defect in proximal tubular reabsorption of uric acid. That's renal hypoyurukemia 1 and 2. Basically, both disorders have no additional phenotype but isolated urolithiasis, and the special feature of exercise-induced acute renal failure. And you will be able to measure on one hand high urate levels in urine, while the urate level in blood is very low, and that's quite a specific finding and should prompt the genetic analysis of these genes involved. And that's why one reason we measure urate always in the urine already at initial presentation. Both of the genes code for transporters involved in the apical uptake of urate into the proximal tubular cell. So again, a proximal tubular defect of an organic metabolite. Now would come to basically one of the classic examples of disorder leading to nephrocalcinosis and kidney stone disease in children. Like shown in the beginning, there has been a specialized talk on hyperoxyloria before. but I like to at least introduce you to the different types shortly. Again, primary hyperoxaluria type 1 to type 3. These, you can see the genes involved, all basically coding for enzymes involved in the metabolism of oxalate. And basically, we have the most severe phenotype provided here on the left side in primary hyperoxaluria 1. We have a significant proportion of patients presenting early in life already with acute renal failure and end-stage renal disease. And we have a little milder phenotype in primary hyperoxaluria type 2 with less risk to lose renal function, but still these patients are at a significant risk of chronic renal failure over time, and you will see this on the next slide. And we have the third entity, primary hyperoxaluria type 3, and these children usually present early in life with severe kidney stone disease, but on the other hand, these basically are supposed to show an amelioration over time with so meaning that they get better or they have been supposed to get better over time, but this might be an oversimplification of the disease, and you really have to closely look at these children, not to overlook recurrent stone disease and deterioration of renal function also in those. But if we look, I will skip the defects now for time, but if we look at the symptoms of the three different disorders, basically I've stolen this nice slide from Jaap Groothoff's talk from almost or a little bit more than 3 years ago. You can see that we have a severe degree of nephrocalcinosis, especially in primary hyperoxaluria 1, shown here in blue. We have a high proportion of patients with nephrocalcinosis and kidney stone disease, and we have these are symptoms at time of diagnosis already. And we see that almost every second patient with primary hyperoxaluria type 1 shows end-stage renal disease already at diagnosis, so meaning that they can present from early infancy on with almost white kidneys as provided here in the ultrasound, and with end-stage renal disease early in life. So I will follow this by an overview on a specific set of proximal tubular disorders, now composed of renal Fanconi syndrome, as well as sort of the classic disorders of the proximal tubule, like dense disease and Lovis disease, sort of classical disorders for patients with nephrocalcinosis and kidney stone disease. These basically are lysosomic disorders of acidification, and I won't go into too much detail with this and concentrate more or less on the clinical picture. Renal Fanconi syndrome itself has usually hyperphosphaturia on one hand and also hypercalciuria, but the risk for developing severe nephrocalcinosis is obviously not as high as in the other disorders, and might also be, like in cystinosis, be an effect of too aggressive treatment of these patients with active vitamin D metabolites, for example, for hypophosphatemic rickets. And the last entity I would like to at least shortly mention is Fanconi-Bickle syndrome, because this is a specialized glucose transporter also expressed in the proximal tubule, and this disorder, next to glycogen storage disease, also leads to nephrocalcinosis and kidney stone disease, as well as severe renal Fanconi syndrome and hypophosphatemic rickets in children. So this is also a quite severe clinical picture that these patients normally show. If we concentrate now on the clinical symptoms that usually patients with Dent and Lowe disease, and I pick these two special entities just to illustrate the complex picture of basically all symptoms involved in renal Fanconi syndrome, like low molecular weight proteinuria, aminoaciduria, for example, phosphate and potassium wasting on one hand, and these symptoms for disturbed calcium reabsorption like hypercalciuria, nephrocalcinosis, and kidney stone disease maybe on the other hand. You can see here that in this retrospective analysis of more than 200 patients, you can see that The majority of these patients showed hypercalciuria and nephrocalcinosis, but I think more recent data point to the fact that this might have been a selection of patients through these symptoms on the other hand, and that a significant subset of patients might present initially with low molecular weight proteinuria and a certain deterioration of renal function that is not in conjunction with hypercalciuria or a consequence of repeated kidney stone disease, but a feature of the disease itself. So basically, I suspect that the clinical picture of the disease is much wider than simple hypercalciuria and nephrocalcinosis and involves all of these aspects of proximal tubular dysfunctions. After talking now about proximal tubulopathies, I would like to switch now to the distal tubule, and my colleague Martin Conrad has presented these data about 4 weeks ago, so I also won't go into too much detail for antenatal Barter syndrome and the other subtypes of Barter syndrome, but I would like at least to shortly mention that these patients typically present with nephrocalcinosis in early life. Usually they are born prematurely because of polyhydramnios and present with salt wasting in the first days of life. Hypokalemic alkalosis develops during these first days, and next to this salt wasting, they show severe hypocalciuria leading to nephrocalcinosis also in the first weeks of life usually. Kidney stone disease, on the other hand, is a rare feature of Barter 1 and 2 only. There are some reports on the development of kidney stones in later life for Barter 1 as well as also for Barter 3. But other than expected, the finding of kidney stone disease in all these types of Barter syndrome is quite rare. Transient Barter syndrome, as the name says, is a transient phenomenon that's caused by a previously unknown factor that's influencing the expression of the salt reabsorptive machinery, usually goes away spontaneously and resolves after a couple of weeks. And though there is a tendency towards nephrocalcinosis and hypocalciuria, also these symptoms disappear. And basically, you won't see these features most likely in patients that come to you with kidney stones or nephrocalcinosis in later life. The situation is a little different in Barter syndrome with sensorineural deafness, BSND. This is the most severe type of salt wasting disorder, and patients usually show a deterioration of renal function and no good response to therapy, especially not with indomethacin or other inhibitors of cyclooxygenase. They have a severe degree of nephrocalcinosis, or on one hand, or can show renal dysplasia, so undifferentiated kidneys, on the other hand, leading to early renal failure in the majority of cases. There is basically a single gene mutation described that has a preserved renal function, and these patients in the majority of cases show nephrocalcinosis. Classic Barter syndrome presents a little later in life, usually with severe salt wasting and a severe degree of hypokalemic alkalosis, but only a subset of these patients show severe nephrocalcinosis. On the other hand, the phenotype might range from patients similar to antenatal Barter syndrome almost to patients presenting with a clinical picture that is not to differentiate from Gittelmann syndrome. And these patients, rather than hypercalciuria, have hypocalciuria, and so they have no increased risk to develop nephrocalcinosis and kidney stones. Here you can see in the distal tubule an overview of the disturbances in the thick ascending limb of Henle's loop on the left side, and in the distal convoluted tubule on the right side, again without going into too much detail, as this has been shown before. You can see here that the antenatal Barter syndrome uniformly presents with nephrocalcinosis and salt wasting pretty early in life, that a subset of classic Barter presents similarly, but the other half of patients basically are more similar to Gittelmann rather than to antenatal Barter syndrome or Barter syndrome type 1 and 2. And these are the patients that are hypomagnesemic specifically at the same time. Okay, so we switch now to the Claudine defects, and in addition to the disorders causing FH, and C, and I will come back to this, I will show you the complex nature of Claudines expressed along the nephron. You see that every part of the nephron has a specific composition of Claudines, and these Claudines make up the specific abilities of tight junctions, either being able to reabsorb a certain subset of electrolytes and water, or to seal the tubule and make it water impermeable, or impermeable to a certain subset of salt on the other hand. And this specific ability of the tight junctions is provided by the composition with different types of Claudine proteins that rather seal the intercellular space or allow the passage of a certain subset of ions on the other hand. Just to provide you an overview on monogenic disorders associated with Claudines, I picked 3 of them. Basically, the Claudine 10 disorder is a quite interesting one that has only been discovered recently. These patients have a skin phenotype because they basically are not able to produce sweat and have an ichthyosis phenotype on one hand, but they show a quite severe renal salt wasting phenotype and hypokalemia, but they have an increased reabsorption of calcium as well as magnesium, so they have hypocalceuria and maybe even a decreased risk of developing nephrocalcinosis or kidney stone disease. So this is basically, if concerning calcium, it's the opposite picture of the 2 following disorders. The classic disorders leading to a combined wasting of calcium and magnesium is the Claudine 16 defect, also autosomal recessive. And the patients usually present with symptoms originating from the urinary tract, like calcifications, kidney stone disease, urinary tract infections, or even secondary distal renal tubular acidosis. And like I said, show a combined wasting of calcium and magnesium. They can show hypomagnesemia and also hypocalcemia and have an increased risk of developing kidney stone disease as well. And I will come to the heterozygote effect a little later on. Basically, patients with Claudine 19 defects present similarly, basically with an indistinguishable renal phenotype, also leading to magnesium and calcium wasting. But this defects in this gene are accompanied by eye defects, usually a severe myopia, nystagmus, and colobometer of the retina. So it's important to get an ophthalmologist visiting these patients. Both of the genes, if classically inherited in a recessive fashion, both of the genes have a significant heterozygote effect, meaning that the parents that are obligate heterozygotes, for example, have an increased risk of developing kidney stone disease, as well as the heterozygote siblings of affected patients, for example, or even sporadic cases. So it's important to keep this in mind if you look at recessive genes that in patients where you only find one mutated allele. And the last example for a Claudine defect now is Claudine 14. Defect maybe is not the right word, because we have polymorphisms in the promoter of this gene, and rather than within the gene defect that's associated with Claudine 14 is a recessive type of deafness, but this is not mentioned here because we are not talking here about coding defects, but rather differences in the expression of the gene. And the reason for this is that the complex tight junction in the thick ascending limb is again shown here, composed of Claudine 16 and 19 and also 10. And usually in the physiologic state, Claudine 14 is not expressed, but as soon as there is an increased concentration of calcium in the interstitium and the renal tubule is supposed to not reabsorb calcium anymore, then there is a negative feedback loop through the PTH receptor, and the Claudine 14 that is normally not expressed is then incorporated in the tight junction, and the expression is upregulated. And this upregulation of Claudine 14 prevents a further reabsorption of these divalent cations through the tight junction and lead to hypercalciuria and kidney stone disease in these children. Why is this important? As you can see here, if we look at kidney stone disease, this now is the single picture on a whole genome association study that has been performed in kidney stone formers from Iceland. And as you can see here, we have 4 different genes that pop up significantly in these people, and the most significantly one was Claudine 14. And because the expression of Claudine 14 was obviously modified by a polymorphism near the promoter of the gene that is upregulating the expression of the gene, leading to hypercalciuria. So the last entity, or almost the last one that I would like to mention, is renal tubular acidosis. Also, this has been provided in more detail in a previous talk, so I will keep things a little shorter. We have a proximal tubular acidosis that usually does not provoke severe nephrocalcinosis, but goes ahead with neurological phenotype. And I don't want to go into too much detail with this one. The classic distal renal tubular acidosis, there is the classic most frequent dominant disorder associated with SLC4A1, or the anion exchanger, that might go along with hemolytic anemia, but usually leads to nephrocalcinosis or recurrent kidney stone disease in children. It's usually quite good to treat, and the patients under treatment are usually able to develop normally and without recurrence of kidney stone disease in many cases. On the other hand, we have a direct defect of the protein ATPase in the collecting duct. And these are the 2 subunits involved here. Both disorders are basically inherited in a recessive fashion, and both disorders are associated with progressive deafness in a significant subset of patients, if not all patients, over time. But this might not be an early finding, and so you have to closely monitor the development of hearing impairment or deafness in these patients. And both disorders are associated with a severe degree of nephrocalcinosis and recurrent kidney stone disease as well. We have seen the heterozygote effect already in FHH and C, and this might also be the case, especially it has been shown for ATP6V1B1 patients that show a milder phenotype, or for heterozygotes with only 1 mutation in the gene who show a milder phenotype with nephrocalcinosis or kidney stone disease in later life without severe acidosis. Again, this provides a short overview on the different defects in the collecting duct, for example, or in the proximal tubule. So as the last point, I would like to come now to hypervitaminosis D, which rather than a tubulopathy is a metabolic defect leading to an increased intestinal absorption of calcium, and then secondarily to hypercalciuria, or on the other hand to primary renal phosphate wasting, as you will see a little later on. If we talk about defects in vitamin D metabolism, the studies basically started in hypercalcemic patients, specifically patients with idiopathic infantile hypercalcemia, which is sort of the classic phenotype in these patients. And if we try to diagnostically differentiate hypercalcemic children, we usually look at the PTH as well as vitamin D metabolites, which usually differentiates between primary defects in parathyroid function on one hand and in vitamin D metabolism in the other hand. We usually use 25-hydroxyvitamin D to exclude overt intoxication. And we have a subset of patients that also show increased or at least vitamin D metabolites, specifically active 125 at the upper border of normal, or also increased vitamin D metabolites that show the classic phenotype with idiopathic infantile hypercalcemia. And I will show you this in more detail later on. So basically, these classic patients present in infancy with a failure to thrive, dehydration, and polyuria. If we look at serum parameters, we specifically see suppressed PTH levels and high or inappropriately high vitamin D metabolites. If we look at urine, we see a changing degree of hypocalceuria at least, and we have to look for hypophosphatemia and also for renal phosphate wasting, and I will show you why in a second. We can treat these children acutely, mainly with IV rehydration, but also with a set of drugs that prevent further absorption of calcium from the gut, like steroids, for example, or by precluding calcium release from bone, like phosphonates. Ketoconazole is not only an inhibitor of P450 enzymes in the liver, but also of the key enzymes of vitamin T metabolism, and it might be also useful for longer-term treatment. In addition to the omittance of vitamin D and maybe the start of a low calcium diet, I have put a question mark after a low calcium diet, because it's important to keep in mind that a low calcium intake might lead to increased oxalate reabsorption. But more importantly, even, we have during long-term follow-up, we have borderline hypercalcemia that is detectable for a long time in these children. The serum parameters like low PTH and high vitamin D metabolites stay constant over a long period of time, even over decades, and we have continuous hypercalciuria and an increased risk of nephrocalcinosis and kidney stone disease. If we look now at vitamin D metabolism in more detail, you can see that vitamin D metabolism, shown in the middle here, is closely connected to phosphate reabsorption via the phosphaturic hormone FGF23, that is also a regulator of vitamin D metabolism. And this is next to the fact that 125, the active metabolite of vitamin D, is also regulating its further production and degradation by increasing serum calcium and regulating PTH by itself, on the other hand. If we look at the different defects in vitamin D metabolism, we have the classic disorder that's today called idiopathic infantile hypercalcemia type 1, with a defect in the vitamin D degrading enzyme 24-hydroxylase. Patients show all the major features that I have shown before, and a renal phenotype with early nephrocalcinosis and kidney stone disease. And if we look at idiopathic infantile hypercalcemia type 2, there was a second subset of patients, basically with an almost identical phenotype, but in addition to the major features, also meaning suppressed PTH and high vitamin D metabolites also, and this was combined in these patients with phosphate wasting. So we looked for an additional gene involved, and we identified the sodium phosphate cotransporter 2A that was mutative, also recessively inherited in these patients in idiopathic infantile hypercalcemia type 2. The pathophysiology basically is a downregulation of FGF23 and basically a disinhibition of vitamin D activation. So FGF is not able anymore to limit vitamin D activation and to promote degradation, and this also leads to high levels of active vitamin D. And in the kidney does what it's supposed to do. It's excreting the excessive amounts of calcium, leading to nephrocalcinosis and kidney stone disease. After the discovery of these two defects, basically we identified additional patients that did not present with a classic recessive phenotype of hereditary hypophosphatemic rickets, but presented also with isolated nephrocalcinosis and kidney stone disease that showed mutations also recessively, and I will come back to this mode of inheritance a little later, in the closely related sodium phosphate cotransporter NAPI2C as well. And this was basically the starting point when we started to screen a large cohort of pediatric patients with either infantile hypercalcemia, but also isolated nephrocalcinosis and kidney stone disease. These were a little more than 400 patients at that time. And we basically performed conventional Sanger sequencing in these patients for these 3 different genes involved. And indeed, we were able, sorry, this is lacking now the description, but we were able in these more than 400 patients to identify pathogenic mutations in more than 150 patients of these 400 patients in one of the 3 genes, meaning that mutations in every of these 3 single genes yielded an explanation for the phenotype in more than 10% of these patients, which was a quite impressive result. You can see an overview on the mutations in these genes. You can see that all of these genes show a set of mutations basically distributed over the entire gene. But more importantly, we have a set of recurrent mutations, especially in the 24-hydroxylase, that make up the majority of all mutations in the patients we identified. But if we look now into genome databases, you can see that the cumulative minor allele frequency, meaning the frequency of mutations of these 4 mutations in the general population, is indeed 0.4%, meaning that these are quite common, maybe you can even call it polymorphisms in these genes, which functionally, or all of those 4 functionally, lead to a complete loss of enzyme function of the gene. And this high frequency would mean that 0.4% or even the double of this, 0.8% of the population are heterozygous carriers of one of the mutation and prone to develop nephrocalcinosis or kidney stone disease as heterozygotes, as you will see. A similar fact is true for the 2 other genes, where we have in each gene a rather common polymorphism or variant with a proven partial loss of function in the gene that is present in a significant percentage of the general population. Here you can see the distribution now with all the numbers provided again, and this is now differentiated in heterozygous carriers only, or patients with a classic recessive type of inheritance, meaning that both alleles were mutated. And you can see that the distribution is almost 50% for either being heterozygous only or being homozygous or compound heterozygous in these genes, meaning that we don't see a classic recessive mode of inheritance for these genes in the disease nephrocalcinosis and kidney stone disease, but we see a significant heterozygote effect, meaning that also the heterozygotes are at risk for developing kidney stones. If we now biochemically look at these patients, you can see that the phenotype with borderline serum calcium levels or hypercalcemia on one hand, and also the suppression of PTH might be a little milder in the heterozygous ones, but is similar or is present to a similar degree either at manifestation but also at follow-up, meaning that also in the heterozygotes these biochemical features stay present during a longer follow-up period. So if we now try to look at studies that looked at larger cohorts of patients with nephrolithiasis and nephrocalcinosis, I would like to show you now the results of the first studies, all performed by Friedhelm Hildebrand in the United States and colleagues that looked at these types of patients. As you can see in this first cohort, they analyzed more than 250 patients with kidney stone disease and only a very few with nephrocalcinosis. Most of them were adults in this first study. They used a multi-gene panel amplifying more than 380 exons of more than 30 genes in these patients. And indeed, they were able to identify disease-causing mutations in 40 of these patients, meaning in about 15% of these patients, like already provided in the title. But the question now is which genes were mostly present or being mutated in these patients. You can see that the percentage of children was even higher with monogenic nephrocalcinosis and kidney stone disease than in adults. But if we look at the distribution in these genes, you can see that the majority of these patients bear mutations in the genes responsible for cystinuria, meaning that these patients, in contrast to the cohort shown before, were not selected for Hypocalceuria or calcium stones, but it was a completely unselected cohort, and the majority of these patients indeed had cystinuria. But the other patients showed a wide distributions, especially including genes for primary hyperoxyluria, dense disease, also a Claudine, and only also to a minor number in the genes involved in distal renal tubular acidosis, uric acid transport, and also idiopathic infantile hypercalcemia. This was followed by another study by Daniela Brown, also from Friedhelm Hildebrandt's group, and they basically did a similar analysis. I'm sorry that some of these numbers here now are missing, but the results were pretty similar. Now it was a pediatric cohort of 150 patients, and only a few adults were included in this group. But again, the results shown here now show that a significant number of these children, like in the study shown before, previous to the other study by Friedhelm Hildebrandt, showed mutations in the genes involved in idiopathic infantile hypercalcemia, and in a lot of other genes involved in different types of disorders I have shown before, like hyperoxyluria, FHH&C, or distal renal tubular acidosis, for example. As you have seen before, we had a subset of genes that, next to the classic mode, recessive mode of inheritance, beared a significant heterozygote effect like FHH&C, but also all the genes involved in idiopathic infantile hypercalcemia and one of the genes involved in distal renal tubular acidosis. I would like to mention here in special. And after providing now a short overview on the first results of these panel testings, I would like to summarize these findings, showing that the hypercalciuria indeed is the major risk factor for renal calcifications in children. Before we initiate a genetic testing of these patients, I believe that a thorough clinical and laboratory evaluation of the affected patients is critical to get an idea of the underlying metabolic abnormality, especially if we don't have calcium-containing kidney stones. The hereditary disorders associated with hypercalciuria comprise renal tubular wasting of calcium, as well as disorders that go along with an increased activity of vitamin D. And I hope I have shown you the importance of the latter entity. And we have different modes of inheritance involved, and it's important to keep this in mind, especially if looking at genes that classically show a recessive mode of inheritance. And these NGS-based molecular studies, free of basically a hypothesis before, are surely able to help to elucidate the spectrum of genes and pathogenic variants involved in pediatric kidney stone disease. And in the end, I hope I have shown you that a multitude of the affected genes are responsible for a small number of affected patients only, underlying the importance of a multi-gene testing again. And we have only few genes with a high mutational load, and I think this especially concerns the genes involved in vitamin D metabolism. yeah, to the end, I would like to thank you all for your attention, and I hope it was not too long, and I would be happy to answer questions if there are one. Awesome. Thank you very much.
Thank you very much, Karl Peter, for a very complete presentation. I think you covered almost all questions which were coming away a little bit late, so I'll just try to ask the questions which were not answered. So there is a question regarding the PAX test. So what do you recommend? Do you think that it should be completely abandoned? And the question is, how do you differentiate the type of hypercalciuria? Should it be completely removed by genetic testing?
Yes, we are not performing this test anymore, to be honest. And I would rather recommend to follow the urine analyses now by the analysis of vitamin D metabolites and PTH, to be honest, in order to detect disorders in vitamin D metabolism leading to absorptive hypercalciuria, rather than to look for or trying to differentiate between absorptive and reabsorptive hypercalciuria by this test.
Okay, another question is, what about high salt intake? Can it be the cause of hypercalciuria? And do you recommend genetic testing in all kids with hypercalciuria?
It's surely a risk factor for hypocalceuria. I mean, this has been shown in adult studies, so we have to keep in mind that we should try to restrict salt intake also in children, as this might at least contribute to the overall risk of forming kidney stones. Also in these children that bear genetic mutations in one of the genes that we have shown. If we have hypercalciuric children, I would recommend to follow the urine analyses by the testing for the biochemical parameters. I think especially the IPTH provides a quite easy method to get an idea if there's a disturbance in vitamin D metabolism involved. This might be the cheapest test of all of the three, and also during follow-up or during later life, irrespective of age of the child, it might give you an idea. It might especially give you an idea if the PTH is still in the normal range and is rather low than high. If we have a tubulopathy leading to hypercalciuria, I would suspect the PTH being significantly higher than in one of the three disorders I've shown you in the end. Especially the tubular acidosis and especially FHH and C in addition. There we have quite high levels of PTH, and this simple test will give you an idea what you're dealing with, in my point of view. And if you have a disturbance here as well, then I would recommend genetic testing for the genes involved.
Okay, good. So some people really thank you for a very helpful presentation. But the last question is about low citrate. So can isolated hypocitraturia be concluded as a cause of nephrolithiasis when all other metabolic causes are excluded or tests are within the normal range?
Yes, I mean, after performing all these kinds of tests, we will still have a subset of children without an identifier cause. And this might even be true for the majority of patients. And then we look normally for these metabolic abnormalities in urine as well. Might this be low citrate or low magnesium levels in the urine, both being known risk factors for kidney stone disease. I mean, in the end, there might be children with undiagnosed disease where we don't know the underlying reason by now. But on the other hand, if we have the hypocitraturia in these patients, we have at least, let's say, a risk factor that we can treat in these children. And as long as we don't have the identifier cause, I would strongly recommend to correct this metabolic abnormality in order to decrease the overall risk of stone formation in these children. And this might be true as well in children where you have an identifier cause as well, but you don't have a specific treatment, for example, for hypocalceuria. Then you can still try to keep the citrate in the normal or high normal range in order to decrease the overall risk as well.
Okay, thank you very much, Karl P. I think the other questions which were coming, you have already answered them. So if people still have some questions, maybe you can write directly to Karl Peter. And I think we have to finish the webinar because we are running a little bit late. But I would like to thank you again for a very comprehensive webinar. It was really very good. And thank you all for your attention. Thanks a lot. Bye-bye.
Thank you very much.